thrombocytopenia, that's the one I forgot, multiple myeloma. And then this was the GI stuff we did yesterday, GI bleeding, cancers, acute pancreatitis, and I guess I should put over here on the side for that one too, those gastric surgeries. Gotta take another picture, sorry. Yeah, it's the same stuff that was up there yesterday.
Yeah, but now it's all like.
But you know,
Alright.
OCD, big thing.
I know. So management of those patients that have those problems and any complications that kind of go along with those. Because remember, anybody who gets chemotherapy, which is a lot of people up here, the neutropenic piece or managing that stuff with people is going to be the same. I guess I should put that up there so y'all.
Yes.
Just in case.
Yes.
As Brenda's like, I'm about to take a picture.
Just don't take pictures yet.
Woo! All right.
I'm like, they just having a ball this morning.
So let me put up here also, just because it's part of the disease process, but I'll put it up here. If y'all like me. So management of patients who have as those things fit in there. So just know that if you have a patient who has chemotherapy or radiation, the kind of things you have to do to keep that patient safe, because it all ends up being around safety and looking at the things they have associated with that. So that's going to be for exam 3, which is on Monday. Then the next exam, this is what this is going over, so I'm going to go over that, and then you'll have time to study, because I don't want to do all of it today, because then you'll have kind of thing, because you're still trying to get your hematology and your GI stuff in there ready for your test. I'm probably going to put quiz 4 online, so I will send an email out for that to let you know, but that way we can stay on schedule. I was up here working on that while y'all were doing that. Crazy. But if we can continue on like we're doing, our exam 4 will be on the 16th, because if we can cover all this stuff today, and then after we'll go over some stuff next Monday and Tuesday, and then your exam 5 will move to the 24th. Quiz 4 will be online, and then your HESI, because the computers should be ready now, so you don't have to go to Dale Mason. You should be able to do your exit HESI on the 30th over here. Unless y'all want to do it on Halloween, I can move it back a day. It's up to y'all, because we should be done with content. Y'all want to go Halloween Horror Nights or
Halloween would be which day?
Huh?
Oh, you guys don't want an extra day? Are you guys kidding? You're refusing an extra
No,
day
they
to
just want to
study?
get done.
I love to take extra day.
Yeah, me too. 'Cause I'm off on at that point I want to work.
No, you're just doing acute blood loss, but that is anemia, but it's from acute blood loss. Yeah.
Not acute, a hemolytic.
If you have a patient that has hemolytic anemia, it's usually acquired, and it's something destroying things. I did talk about it, but I'm not going to focus more on it. Now, you can have a patient who does have hemolysis when they have leukemia, because sometimes a patient who has leukemia presents with jaundice. It's one of the things they can present with. All right, so like I said yesterday, and you guys kind of were nodding the whole time, that a lot of these things, when you read them, sound exactly the same, so kind of look at those things that make them different. Look at that box about the leukemia, because you may have something that talks about the cells, or what kind of assessment findings you see in the patients, what cell types may be specific to a different condition that a person may have, because those are the things that make it a little bit different. But overall, when you think about all of these patients, if they're going to get chemo and radiation, treatment is, that part of it is the same. Know about the stages of how you do chemotherapy in patients, like I said, because that could be something that gets you points somewhere in life, like next week. All right, so look at those things and what's characteristics for patients when you're talking about chemotherapy. Because you need to know the difference between consolidation, intensification, induction. Okay, those are the kind of things we're talking about. Nobody ever goes on maintenance until there's no cancer that they see anywhere else. Because what you're trying to do is make sure that patient stays cancer-free. So you need to know the characteristics of what you see in the patient because of those stages of chemotherapy. All right. So the next test has to do, if you think about fluid and electrolytes, that's where the test is going next time. We're talking about patients who have burn injuries, and then we're going to be talking about acute renal failure. And some other things in renal, but acute renal failure is a big piece of that because unfortunately most of the time we see that happen to patients is something we've done to them. Now patients have it for other reasons, but a lot of times it's response to therapy of things that we've done to patients. Especially people who get contrast dye, medications, all those things that we talk about as we go along. They're contraindicated for patients, but we do them anyway as far as treatment goes. So it's a multi-system problem when you have a patient who has a burn injury. Larger percentage of body surface area burned, the more problems you're going to have with the patient. That's how you have to think about it. Because we all know if you burn yourself in your kitchen, you deal with it, localized, painful, but you're okay. Also, those people that go out and sunbathe, you know that you go back in the house and you hurt all over because you went to sleep after you drink your Corona out there. And you went to sleep while you're out there, and then you can't put on clothes for a couple of days, kind of thing. It's more generalized kind of things you have with patients. So always think about more body surface area burn, the more problems I'm going to have with the patient. So when we're going to talk about this again next week, but just to give you the lead up to what we're going to be talking about. So when you're talking about burn injuries, you always talk about the mechanism of injury that they have or the type of burn injury. So you're talking about something that's thermal, which is either from fire. You can have radiation, which you get from the sun, but also from radioactive material kind of thing. You can actually have chemical burns, which are bad. You know, chemical burns are ones that are problematic. All burn injuries are bad. But when you talk about chemicals, some chemicals continue to act on skin and tissue for hours. So even though you get it off the surface, it could still be burning the patient for hours on end until you actually end up, you don't know how much is viable until that burning process is stopped. So acids and bases are the kind of things you're looking at in that, going back to your chemistry kind of stuff. You can also get burned from cold. That's frostbite. We don't have as much of an issue of that down here. Except for every single year when it gets really cold down here, somebody tries to figure out whether they can put their tongue on something metal and it not cause a problem. You have people that come in the ER with half their tongue taken off the skin. I'm going like, well, how stupid is that? But people do that kind of thing. Or during the summertime, our big burn injuries are associated with barbecuing. Okay. People don't realize that when you set up your barbecue and you put the lighter fluid on it, that's all you should be doing with it, you know, with the lighter fluid. Some people wait till they light it and then do this kind of thing, squeezing more lighter fluid on. You don't realize that the fire can light that arc and then it explodes in your hand. So those are kind of things that we actually have with patients, all different types of injuries, all kind of craziness that goes along with it. You can also get burned by steam. So those are things that happen. Sometimes people are opening a radiator cap in a car. Should wait till the car cools off, but people do that. Burns the top of their head. It's craziness, but these are the kind of things that happen to folks. And you kind of look at them like, what is wrong with you? And you know you weren't supposed to do that. So the issue that you have, that we have all kinds of things that happen to patients. Patients who go to sleep on a heating pad. You know, different types of reasons that you can have that. So the big issue that you talk about for one of those things is talking about prevention. So who do you tell about things that they should be doing and should not be doing? And who is at risk for those things? Because kids are like playing with all kinds of stuff. Elderly people, because they can't sense temperature, those types of things. If they have chronic conditions like diabetes, puts them at risk. So a lot of prevention about fires and that type of thing. So when we talk about the patient actually receiving the burn injury, so we talked about the different types that you have. Oh, I forgot electrical. That's the other one. Big one that's there. Some of those we might have had during the hurricane, people putting things back together. Electricity is the one that always goes to the area of least resistance. So you may see a patient who has an electrical burn that you don't know exactly how much of the body has been burned because it goes, you can have an entry and an exit. So they'll have an entry someplace and it might blow their toe off. essentially. But remember, to get that energy to that spot is burned all the way down. So it usually goes along tendons, along bones, those types of things that happen to patients. So those are things that sometimes you don't realize how much of a problem you have. Then going back to the test you just taken, all right, if you're in contact with electricity, what are you doing to yourself essentially?
Defibrillator.
You're doing the defibrillation. So a lot of times, even if the patient is up and around walking, we still put them in the hospital for a couple of days because you can have disruptions in rhythm that happen after electrical injuries. So it's one of those weird kind of things. It also, because it messes with, it does a lot of muscle damage, is that a lot of times electrical burn patients, you actually want to put out more urine than other types of patients. And we'll talk about that fluid resuscitation thing. So we talked about injuries related to depth of injury, how much tissue has actually been destroyed. You know, we used to talk about first, second, and third degree burns, and people still talk about them that way. You'll see that sometimes still, but there's new ways you're supposed to designate how much body surface area is burned, and it's actually supposed to be superficial, partial thickness, and full thickness burn. So we're talking about how much body surface area is burned, or how much the depth of injury, I'm sorry, that the patient has. So I always think about anything on that first layer is going to be painful because that's where your nerve endings are. That's the perfect example of somebody who's sunburned. You know how you're just walking around and then you're sunburned all of a sudden, and then just putting on a bra or shirt, everything hurts. So a lot of nerves are there, so patients tend to have a lot of pain. Partial thickness burns go down to the second layer, so it goes below the dermis, and you're going to start seeing some, you still have pain associated with that, but you also have a lot of blistering and those types of things that can happen to patients who have partial thickness burns. So you still have function, still, you know, viable tissue can come from that, but you have to act on figuring out some other things about the patient that happened with the injury. But part of what you do when you have a burned patient is that there's going to be some things you do that are always going to be the same no matter what. So not just for this class, but for HESI and also for NCLEX, you got to do all the time. Because we got to figure out the depth of injury, how much body surface area was burned, and fluid resuscitation. Those are the big things you do for those patients. So we have full thickness burns, that goes down to bone. You may actually see tendons. This burn injury is not painful because the person doesn't have nerve endings, it's burned everything off. Those are traumatic to watch because you know this person's going to probably end up losing an extremity or something that's associated with that when you talk about burn injuries on extremities and that kind of thing. So that's what when you have full thickness burns, there's nothing left as far as nerve endings, so that patient doesn't have that. The bad part about it, of course, is that burn injuries are not always going to be just one or the other. Most patients have varying degrees of injury based on how long their tissue was in contact with whatever the source of injury is for the patient. So a person who has superficial burns may also have full thickness burns associated with it. So you'll see both of those things together. The major difference that you see is the pain kind of thing. So full thickness burns, no pain. There's no blistering, that kind of stuff that happens with your patient. When you're talking about superficial and partial thickness burns, painful, and there's blistering that happens with them. Okay, so this is one of those times we talk about third spacing in patients, because that's the issue that you have with a burn injury patient. So we figure out the mechanism of injury is not the greatest thing you have to figure out, other than if what you're dealing with, if it's something, if it's a chemical thing, you got to figure out what it is that the person's been exposed to. But then it becomes, like I said, figuring out how much or how deep that burn goes, and then figuring out whether or not it's a major burn versus a minor burn. So major burns are burns that are they talk about 30% of your body surface area is being burned in a patient. Minor burns are 15, in between that 15 to 30%. One thing is, or there's a couple of things that make a burn major, even if that's the only thing that's burned. Okay? So they're talking about body surface area, we talk about major versus minor, but there are some things, even if the only thing that's burned makes it a major burn. Burns of the face, because the face is not 30% of your body, but it's considered a major burn. If your hands or your feet are burned, they become major burns. And it's all about what rehab and reconstruction and airway and all that kind of stuff that makes those major injuries. So your hands or your feet, because that's a rehab issue. about the patient being able to move, that kind of thing. Because if you do hands, it's probably about 5% of your body surface area. So it's not like the whole 30%, but because of where it is and what it does for your body, that's why it's a major burn. The other piece that makes it a major burn is perineal. So if you have patients who have burns on the genitals, that makes it a major burn because of the potential for infection. Okay, so 30% is considered a major burn, but if you only had a hand burn, that would be a major burn. If you had a foot burn, that will make it a major burn. If your face was burned, that will make it a major burn. Because one of the things that kind of does that, if you think about when a person is burned in the face, or that kind of thing, even though you bleed a lot when patients have facial injuries, the nose and the ears don't have a lot of blood supply. So you need a lot of reconstructive kind of stuff that happens to a patient when they have facial injuries. Okay, so that makes that a major injury just because of where it's located. So once you figure out how much body surface area is burned, you looked at the depth of injury for your patient, the next thing becomes that we have to give the patient adequate fluid resuscitation. So there's a formula, opportunity for math. All right. All right. So there's a formula that you use for a patient that you're going to do for fluid resuscitation. Okay. Called Parkland formula. It was developed in a hospital in Texas, Parkland Hospital, which is a trauma center. And one of the things they did was try to see how they could minimize the effect of the fluid shifts that happen after burn injury. Because when you burn tissue, one of the things that's going to be released is potassium, but you're also going to increase cellular permeability. So all of those things are going on. Because of that, you can have fluid shifts that are happening with the patient. And when you do that, it makes it not available to the body. So if you have a large body surface area burn, you are going to have a shift in fluid. What this formula does is try to give the patient enough fluid so that it minimizes the effect. So the seesaw doesn't go like this, but it goes like this. Okay, so you keep it more even when you're talking about the patient. So to give this to the patient, you're going to use lactated ringers, isotonic solution that we're going to use for the patient. Okay, so lactated ringers is going to be multiplied by kilograms of body weight that the patient has, and it's going to be multiplied by 4. So it's body surface area burned by kilograms of body weight by the number 4. Okay. And when you do that, that's going to tell you how much fluid the patient has to receive for the first 24 hours. So body surface area burned multiplied by kilograms of body weight of the patient multiplied by 4. And that number is going to equal how much you have to give the patient for the first 24 hours. Now there's an application piece to this. Okay. So body surface area burn times kilogram body weight times 4 equals the first 24 hours. The patient gets half of that in the first 8. So you get half of the amount of fluid that you estimate that this patient needs in the first 8 hours. They get another quarter the second 8, and the last quarter the last 8. Now the reason you're giving them so much fluid up front is because you're trying to prevent that shift that happens with a patient. And think about it, there's also a picture in your book. Any person that has a burn injury comes into you looking like their normal self. The next day, they look like they blowed up. And that's because now, because of the tissue permeability that happens because of the injury, they're going to move fluid from the vascular space to the interstitium. So that's what accounts for the edema that you see in a burn patient. So what I'm trying to do by giving them adequate fluid resuscitation is prevent them from having all the signs and symptoms of hypovolemia because of that. That's the burn shock piece. Because you have a shift of fluid from the vascular space to the interstitium. So there's a picture in your book. If you look at the burn patient in there, she's puffy, got an NG tube coming out, all this kind of stuff. So you have a person who is skinny today. Lynn looks like me tomorrow. Because that's what happens. You have this shift of stuff that's happening with your patient. So if you give them adequate fluid resuscitation, you're going to get good urinary output. You're going to have the blood pressure stay, even if it's low, they still have a systolic blood pressure above 100, and heart rate stays below 100. That's what you want to happen to the patient. So if you don't give them adequate fluid resuscitation, you're going to see the opposite. The patient's going to show signs and symptoms of hypovolemia. and they're also going to have low urine output. So that tells you you haven't given them enough fluid. Okay? So just as an example, say the patient had, and oh, I forgot, you got to do rule of nines first because you got to figure out how much body surface area is burned. So think about rule of nines because that's what you're going to use. Lund-Browder is more accurate in which you'll usually see used in burn centers, but if you're getting a rough estimate of how much body surface area burned, everything has multiples of 9. So an arm is 9, the whole arm. So you know it's opportunity for math, right? So you would get the whole arm. It wouldn't tell you it's only the one anterior surface of the arm. It would tell you a whole arm. So an arm is 9. This other arm is 9. My head is 9. The front of me is 18. Okay? The back of me is 18. Because this is considered like 9 and 9. Okay? A leg is 18. So the front of a leg is 9, the back of a leg is 9. Okay? The perineum is only 1. Don't care what the guy says. I'm so bad. All right? So that's how you count the rule of 9. So you have to add up how much body surface area is burned. So if I said both of my legs were burned, that's 18 plus 18. Okay, so that's how you would calculate things. Okay, so if you had both legs and one arm, it's 18 plus 9. Okay, that's how you figure it out. So you're going to calculate that for a patient. So we're going to have both legs and the arm. Okay, so that is 45 times, you know we're going to make them 220 pounds. Because that equals 100 kilograms. Okay? Then you multiply that by 4, and that comes out to some ghastly number.
54, 44, 12, 16, 1800?
18,000.
It's a lot. That's all I know.
18,000.
All right? So that is how much your patient should get for that first 24 hours. But they're going to get half of that in the first 8. Okay, so you would divide that in half. 9,000 you'd have to give in 8 hours. It's a lot of fluid. But what it does is minimize the effects of what's happening with the patient. Okay, so it keeps the blood pressure up, keeps fluid going to the kidneys, so their output is good. Those are the things that you're doing for the patient. Okay? Now, one of the things you got to remember is the clock starts ticking at the time of burn injury. So if it took you 2 hours to get somebody out of a car, you only have 6 hours to give that 9,000. That's the way that works. It doesn't matter. It's when the injuries start, it's when the clock starts. So if it takes you a while to get them out, you're going to have to adjust your fluids that way. Because the changes and the shifts that are happening in your body are already happening, even though I can't start your fluids yet. So that's how you have to look at what's happening with the patient. Okay. So that's how that application of what happens with your patient. But the burn shock piece of that is that's the essential thing that's happening. You have fluid in the vascular spaces going to the interstitium, so the patient gets interstitial edema. And they also think about what's happening with the patient is you're going to actually end up seeing them. Everything is, you start to have hemoconcentration more than likely. So H&H is going to look fantastic because the patient is dry in the vascular space. They also are predisposed to clotting because all of those things, if you take the fluid out, it's just dry essentially. So the person's going to be more at risk for having strokes, thrombus, that kind of thing that's going on for the patient. Potassium is high because injury to tissue releases potassium. So then you got to worry about rhythm issues when you talk about a patient who has burn injury. The other thing about burns is because you lose the protective piece of skin, so you got to worry about infection. That's why I put it there's a multi-system problem. Even though you're talking about skin, it affects every body system that the patient has. Now you know that tends to happen anywhere we talk about that mobilization of fluid from the vascular space to the interstitium, tends to happen somewhere along in that first 24 to 72 hours. You're going to see the person blow up. Okay? Then once you start getting the fluids right, then it's going to go in the opposite direction. The burn shock also goes through a diuretic phase because it's hypovolemic phase, diuretic phase. So you know what's going to happen now, right? What happens with diuresis?
You're going to pee a lot.
You're going to pee a lot. So urine output goes up. Now you got to worry about somebody being in fluid overload because the shift is going to go from interstitium back to the vascular space. So in that time, you're looking for a person who has fluid overload. Who's going to be your people at risk? Anybody who has what kind of problems? Heart problems or kidney problems. Because remember, if you have kidney issues, you can't get rid of it. Okay, if you have heart problems, you can't pump it along. So those are going to be the people you worry about a lot who have those kind of issues because they can't get rid of the fluid now. It's moving from that interstitium where you saw the edema that's there in the patient, and now it's moving into the vascular space. So if it has nowhere to go, it's going to end up in places where it shouldn't be, meaning that you're going to have it in the lungs, you can end up with pleural effusions, all that kind of stuff is happening with your patient. So those are the kind of things you're looking at for what happens with the burn issues with patients. So burn shock has two phases, hypovolemic and diuretic. And everybody is variable about when they get there, but most things say general, 24 to 72 hours for the first phase, and they say the same thing for the second. But you're looking at the symptoms and things that the patient is doing and tell you which one is which. Now, adequate fluid resuscitation means I have output at least 20 cc's per hour, because you're thinking about how much urine this person should put out. So if they're not doing that, you may have to increase the fluids. If you have a patient who has electrical injury, we actually want them to put out somewhere between 30 and 50. The reason you want them to do more is that the damage that happens because of the electrical pathway going through the body releases myoglobin. Myoglobin is a large molecule that doesn't filter well through the kidneys. So patients who have electrical injuries not only have to worry about the issue of defibrillation to the heart, you also worry about renal failure associated with that large molecule. So that's why we make sure they actually put out more urine. But patients may look fine, because a lot of people get struck by lightning because they don't have sense enough to go in the house in Florida. If you can hear it, you shouldn't be outside. But people stay outside because I don't see the lightning bolt kind of thing, and then it comes down and strikes somewhere very close to you. Remember, it's going to travel. That's the issue that you have. And if you come in contact with electricity and you are static, remember, that means you're getting a defibrillation continuously. That's why people who are, if you get come in contact with electricity and you fall and break your contact with it, yeah, it hurts, but that's the person that's alive. Even though you may end up with fractures, you're still alive. But if you stay in contact with it, which usually happens when people have stuff in the house and you're brushing your teeth or something, you touch a sink, and you're just in contact with the sink, that means you're getting continuous defibrillation. If you're a person that's in a cherry picker, which sometimes we have people outside cutting things, and you just fall down, you're going to get zapped, but you are still alive. People that stay in contact with stuff, that essentially burns you up kind of thing. All right. So one of the things that you want to make sure you do, always look at your ABCs with patients, but you always stop the burning process. Because remember, if a person is burning, they're going to burn up. I worry about airway later. If you let them keep burning, you ain't got to worry about airway because they're going to be dead. Kind of thing. So you don't want to do that for patients. So make sure you do that. All right? You're going to have a lot of electrolyte imbalances that happen during the acute, because you only worry about the acute phase. It's not that part about patients getting jokes, stockings, all this kind of stuff to prevent contractures, all that. You think about the acute phase of burn injuries. Because all that other stuff is in the convalescent phase and what happens with your patient. Early on, patients will get, and this is the thing that sometimes people think people get a lot of, but remember, large body surface area burn, person's not going to be able to metabolize anything that they eat. So that means that you're going to actually have to give them all their pain medicines, medications, all that kind of stuff needs to be IV. So initially, that's what you're going to have. Because the body shifts, if there's no blood in the vascular space, it's definitely not going to GI system. So patients can have ileus after a burn injury. It had nothing to do with having any type of surgery or anything. It's just that the body's only trying to feed what it thinks it needs to feed. And the GI tract is expendable. I don't need that right now. I'm trying to save my head and my heart. That's all they're thinking about. So those kind of things, you make sure you monitor the patient for. So this patient, because of their stress and those types of things, go on one of the proton pump inhibitors or H2 antagonists. Patient needs a lot of nutrition. When they do have a return of bowel sounds, you put a person who has a burn injury is in a hypermetabolic state. They need to eat tons and tons of calories that they couldn't even eat if they tried. You know how we always talk about, I'm so full, I'm going to die? These people have to eat sometimes 10,000 calories in order to address the needs that they have when a burn injury.